Okay, get rid of that. Okay, so one announcement is the PowerPoint for Monday, because I'm hoping to finish respiratory stuff today. That's up. That's going to be kidney physiology. So I wish we could have covered it when we had the kidney lab, but at least some of it will be review when you get to it in lecture. A reminder that next week in lab reports are due in print. Okay. And then of course our lecture exam, which I think I've gone over that, sent the breakdown. So I don't need to say anything else unless you have a question about it. And the other thing is, this is the scores page. And this is, of course, the donation thing. And a lot of you have done that. Thank you. Instead of the 20th, I am bumping it up to the 12th. So it won't go to the 20th. It'll go to the 12th. The reason for that is this guy from Black Creek is actually coming on campus to give a presentation on reptiles and amphibians. And I figured if he's on campus, I could give him whatever supplies we have rather than have him have it to come all the way to campus again. So I bumped it up a little bit. So if you're thinking about making a donation, the 12th is the last day. All right. In fact, it'll be probably the 11th at 5 p.m. because I'm picking them up early that day to bring them to that person. So anyway, any questions about any of that? Okay, so let's back out of a bunch of stuff here and get back to lung cancer. Not the best way to start a Friday morning, but okay. Okay, we left off talking about this, so I'm gonna move on. We only have 2 more cancers to go over. Squamous cell cancer, I said this is the one that starts in the bronchi. So, you know, the only way you're going to tell this if someone presents with symptoms, coughing, wheezing, difficult breathing, possibly coughing up blood, and then radiograph or more likely a CT scan. I've included additional information if you're interested, but it's not required reading. All right, I just put some extra stuff up there. Not surprisingly, often linked with a history of smoking. Remember, I said you're taking in foreign material into your lungs, and it can get into your alveoli, but it is passing through all your respiratory tract. Your body's immune system responds to foreign material with inflammation. And if you keep doing that behavior, you have chronic inflammation. And what I tell you about chronic inflammation, I harped on it on Wednesday. What are you prone to? Scar tissue. And if you get scar tissue and your body's still trying to repair, what are you then possibly prone to? Cancer. All right. Mitosis out of control. So one follows another. So catching it early is the key. Okay. Large cell carcinoma is the last of the non-small cell lung cancers. Appear in any part of the lung. No particular one. The first one I talked about, adenocarcinoma, starts in the mucus secreting cells. The other one, squamous, starts in the bronchial tubes. This can be anywhere. All right. Can grow and spread quickly, which makes it harder to treat. But of this group of cancers, it is the least infrequent of the non-small cell. Okay. Now the next one, get rid of that. Won't do it. Okay. Okay, this is kind of at a glance, if you want to study them at a glance. So the adenocarcinoma, the most common, then less common, and then least common for these types, all right? Starts in the mucus cells, starts in the bronchi, can happen anywhere. Now, the next one is the bad one. I'll move this. This one is the most aggressive. It's small, it's hard to detect. It grows rapidly, and it has the highest mortality rate associated with it. So usually starts in the bronchi, in the center of the chest. So that makes it kind of look like the squamous cell, non-small cell, but it's not. But the big thing is they're small, making them hard to detect. They grow fast. So if someone's not keeping a good health check on them, it can progress to metastatic cancer very quickly. And this is the one that has the highest mortality. So do not memorize these. I'm just giving you an idea. Okay. So comparing 5-year survival rates after diagnosis for the non-small cell, all right, those 3 that I talked about, and then 5-year survival rates for the small cell. And this is based on between these dates from, I think I got them from the CDC. Okay. So once it's been detected, that's why you get the diagnosis. Hopefully it was diagnosed when it was still local. And that means it's still at the site where it started, where it formed. That's what localized means. So when you catch it at the localized stage, and that can be stage 0 or even stage 1, A 61% survival rate after 5 years. That's awesome. Okay, that's a really good chance. Once it's spread past the point where it formed, and then it's called regional. So maybe it's moved to some tissue nearby. Then you see the survival rates halved. And then once it's metastasized, we're talking like stage 3, stage 4, it's everywhere. It can be in the brain, in the bones, everywhere. That makes the percent survival go way down. So catching it early, so you get your patients come in and they're chronic smokers and maybe they're having some coughing, things like that, might convince them to maybe get scanned. Because if you can catch something early, you're up here, not down here. Okay, now that's for the non-small cell, which has the higher survivorship overall. This one, come on, I was trying to read that. Stop trying to go to my, there we go. So if you catch it where it formed, 27% survival rate 5 years after diagnosis. That's not great. That's the bad cancer. If it's spread just a little bit nearby, 60%. If it's metastasized, half of that. So early detection, you know who's going to be on the front lines of that? You guys, because you're spending more time with the patient, talking to them, maybe seeing a potential problem or a serious health risk or health, risk factor. You talking to them could be the deciding factor in them saying, okay, I'll do that test, right? So anyway, that's all I wanted to go over with you, is that you end up taking the patient history and really talking to them. All right, so this is, we did not cover seasonal flu, but that would be a good thing to cover in the respiratory system. But I figure you probably get vaccinated every year for the flu, and as future nurses, you're going to be required to, unless you have some extenuating circumstance, because you don't want to bring those things into a hospital with vulnerable people. But the reason, do you know why they have to do a new flu vaccine? It's different from last year's flu vaccine. Mutations, viruses mutate very, you know this from COVID, now you've lived it. All right, so I don't think I have to harp on that. We covered cystic fibrosis, pneumonia. We didn't cover tuberculosis. And then this thing is hiding this. Emphysema, asthma, chronic bronchitis, and lung cancer. And then we've covered more things like COPD. Tuberculosis, you think of it as an ancient disease, right? You'll see it in hospitals. Does anyone know any, especially if you took microbiology, especially if you took with Dr. Pryor, because he covers it. What's the significance in this modern age and time of seeing a patient show up with tuberculosis? What would be going on possibly with that patient that normally works, but it's in our environment all the time? We don't get sick with it because our immune system's pretty competent. But what would be the significance of someone actually testing positive for tuberculosis? Any idea what the underlying thing going on for a patient that's actually coming down with tuberculosis? Think about this for a second. Anything? Could they be immunocompromised? Yes, AIDS patients. They show up with tuberculosis. Anyone who's taking immunosuppressants because they have an autoimmune disorder, they're suppressing their immune system to slow down their disorder. But because they're suppressing the immune system, it can then become vulnerable to things like tuberculosis, which a normal immune system keeps at bay. All right. So someone showing up with that. Or the other thing is they've traveled to a foreign country where it's an epidemic. That's a possibility. But more often than not, their immune system has become compromised by one way or another. Okay, so moving on. This is the lab that we couldn't perform, unfortunately, because of COVID, but it was a really cool lab. But this is something that's done in a hospital or a clinic. If someone comes in with any kind of respiratory disorder, you kind of want to do some tests to find, is it a restricted? Is it obstructed? Find out what it is so you can treat it. And so you literally hook up to a spirometer that's hooked up to a computer like we would do in lab, and you would take all kinds of readings like functional vital capacity, expiratory volume, all kinds of, these are different levels of them. And there are normal values for men and women. All right, so spirometry is something that you might see done in the hospital to help diagnose or see how bad a respiratory condition is. And it's a very simple thing to do. So some respiratory vocabulary, which I would expect you to know. Apnea is absence of breathing. When you have the A in front of something, that means absence of. And then dys, when you have dys, it usually means disorder. Remember when we talked about dysgeusia in the taste lab? So this is labored or difficult breathing. And then normal breathing is just eupnea. Hyperventilation, hypoventilation, those are common terms. Hyper means excess ventilation. They're breathing too rapidly. Now, whatever your respiratory system is doing, it has the most powerful effect on your blood pH. If you are hyperventilating, you are actually ventilating too rapidly. This can be bad. You're losing too much CO2. And what happens is, I'll put it here. Come on, pen, wake up. With this, you, wants to be red. I'll do it. Lose too much CO2 from the blood. CO2 is acidic, right? So if you're losing too much CO2, you're losing too much acid from your blood. What shift, what's it called? The shift in your blood pH that occurs when your blood pH is, instead of being lower, it's higher than it should be. What's that called? You'll have alkalosis because you're losing too many acids, and that's bad. Okay. The opposite happens with hypoventilation. You are not ventilating enough. You're not getting rid of enough CO2. You're retaining CO2. So you retain, come on, pen. It's responding to my fingers touching. Hold on. There we go. No, I don't want it. There we go. You retain CO2. You're retaining acid. And so now you have the opposite problem, acidosis. Okay, which is bad. So when you get into those hospitals and you're working and people have respiratory disorders, they're going to have blood pH balance problems too. And so you're going to have to be watching that all the time. Pneumothorax, I feel we've covered really well, so I don't feel like we need to go into that. And you now know a couple of ways that the pneumothorax can happen. There's actually many ways it can happen. Okay, so we've covered a lot, but now we're going to get into gas exchange at the tissues, and then we'll end with some hemoglobin disorders. I think we'll have the time to get through that. Okay, remember how I said when you're at the lungs, the alveolar sacs, the pulmonary arteries are going from the heart, from the pulmonary trunk, they branch out into left and right pulmonary arteries going to the lungs, the left and right lungs. And in textbooks, those pulmonary arteries are colored blue because they're carrying oxygen for blood from the right side of the heart. But they're arteries and they're always going away from the heart, and that's true. So you have pulmonary arteries, tiny little arteries that meet at the alveolar sacs. And then you have pulmonary veins in textbooks that are colored red because they're carrying oxygen-rich blood, and they're called veins because they're returning to the heart like all veins do. So at that alveolar capillary plexus, you get the arterial blood, you get the venous blood, and the gas exchange is happening based on pressure. Inside the alveolar sac, oxygen is high. Inside the pulmonary artery, it's low. So oxygen goes from high to low, from inside the sac into the pulmonary vessel, returns to the heart with the pulmonary vein. Now it's got oxygen. Pulmonary artery, low oxygen, high CO2. Alveolar sac has low CO2. CO2 leaves the pulmonary artery, goes into the sac, and the next time you exhale, bye-bye CO2, it's gone. Same thing happens at the tissue. Arterial blood coming to your tissue has high oxygen, low CO2. The tissue, we know from metabolism, CO2 is a metabolic waste product, especially like in the Krebs cycle. So the tissues are going to have high CO2 if they're metabolizing and low oxygen. The systemic artery now has high oxygen. Tissue has low. Oxygen will go for it's high in the artery, cross the membrane into the tissue, go to the tissue. CO2 in the tissue is high. CO2 in that artery is low. And then the CO2 leaves the tissue, goes into the artery, and the artery becomes a vein. Do you know at that capillary level, arterial blood meets venous blood? There's a merging. Right? If you look at your anatomy textbook, that capillary plexus, it switches over from artery to vein. Okay, so it always goes from high to low. That's it. That's all you need to know. So in a future exam, not this third exam coming up, but the final, I'm going to give you a scenario. Partial pressure of oxygen in the vessel is this, and in the tissue is this. Which way is it going? just look at where the number's higher and where it's lower. It's not a trick question. It's simple physics. So in the alveolar sacs, oxygen is 105 something. In a pulmonary artery coming from the heart, but going to the lungs, it's got low oxygen and high CO2. CO2 in the sac is low. In the artery, it's high. So first of all, the CO2 leaves the pulmonary artery where it's high into the sac where it's low. And then when you exhale, it's gone. Oxygen is high in the sac, but low in the pulmonary artery. So it leaves the sac, goes into the pulmonary artery, which becomes a pulmonary vein, returns to the heart with all that oxygen. All right, high to low. That's all it is. Okay, so tissue. Here's the muscle tissue, fibers. Notice the O2 is something less than 100, but in the systemic artery, it's 100 and possibly a little higher. So the big arrow means it's going from here to here. So oxygen's going into the tissue where the O2 is lower. In the tissue, CO2 is something higher than 40, but in the artery, it's 40 or possibly lower. So CO2 leaves the tissue, goes into the artery, which merges into a venous system, and then returns to the heart, and the whole process starts again, just like that. So textbooks love to make this physics of gas exchange seem really complicated, but it isn't. Where's the number higher? Where's it lower? You know where it's going. It's not going to go in the opposite direction. That's all there is to it. Now, regulation of respiration. We're going to get back to our friend, the medulla. Okay. And we're getting back to our aortic arch and carotid artery sensors. We know from the blood pressure, chapter 1, and then the lab report you're working on, that there's baroreceptors that detect pressure of blood in those arteries. Those arteries, those locations also have chemoreceptors that sense chemistry. pH is chemistry. It's hydrogen ions and hydroxide ions. So if blood pH drops or rises outside of normal range, your chemoreceptors in the aortic arch and carotid arteries are going to detect that. So you have arterial chemoreceptors located in the place that you know very well now. And the medulla itself has chemoreceptors. Your medulla is not exposed to blood pH. It's exposed to cerebral spinal fluid pH because it's CSF that bathes the brain directly, right? So there's two places for your body to sense pH that's out of whack. And if blood pH is out of whack, then CSF pH is going to be out of whack too. Okay. So you have blood pH that rises too high or drops too low. It's sensed by chemoreceptors. There's going to be an integrating center. Really, there's two, but functionally there's one. So what controls your breathing? If I stick with what I was just beginning with, sensed abnormal pH, the chemoreceptors detect it. They send a signal to an integrating center. That integrating center is really going to be the medulla. The pons is involved. It has two autonomic respiratory centers, but the medulla controls what the pons does. So the medulla is in control of everything because it has a cardiac center, a vasomotor center, which you're writing about, and then it has a respiratory center that controls everything else. All right. So we'll get to that negative feedback regulation of blood pH. Now, voluntary breathing, you can make yourself, and you can breathe rapidly or slow down your breathing. But when you're unconscious, you are not in control of your breathing. But when you're conscious, you can make voluntary changes to your respiratory system. That's in the motor cortex of the frontal lobe, where all voluntary muscle movement happens. But when you're not thinking about it, when you're asleep, whatever, the autonomic center is really the medulla. And I'm going to keep it simple by just saying, focus on the medulla, because that makes it simpler. It is more complicated, but this is a 200 level physiology, not a 400 level. So we'll keep it simple. So there is going to be negative feedback. So we didn't have the lab, so I have to just explain it here. Minute ventilation is the rate, how fast you're breathing and how deeply you're breathing in 1 minute. That's why it's called minute ventilation. Okay. Now, changing your minute ventilation happens pretty much autonomically. If your blood pH is shifted, your medulla, the integrating center, will send a signal to respiratory muscles, diaphragm and other muscles, to either increase minute ventilation or decrease it to fix the blood pH. So sensor, the chemoreceptors. So the stimulus is blood pH too high or too low. Sensors, chemoreceptors. Integrating center, the medulla. Its response, change minute ventilation. And the effect will be a fix in the blood pH. So what happens to minute ventilation after, if someone's been hypoventilating, they've been holding their breath or just aren't ventilating very well? So that's the vocabulary term we covered last time. You're not breathing enough. So I don't think I have it. Do I have it written down? Yeah, I do. So when you hold your breath or you're not ventilating enough, you're not getting rid of enough CO2. That CO2 is more of it's being retained in your blood. It's acidic. It's going to make your blood acidic. And since it's becoming acidic because of what you're doing with your respiratory system, or not doing in this case, it's called respiratory acidosis. You got to fix that. That's going to cause a lot of problems. So the stimulus is high blood CO2. Someone could say low blood oxygen. Sensors are your chemoreceptors. All right. Integrating center is the medulla. And here's what it does. It will increase your respiratory rate and depth. So you blow off that extra CO2. That CO2 is now leaving your circulatory system, making your blood pH come back up to what it should be. Here's a perfect analogy. All right. If you've done the stairs in McNair or at Leatherman, right? 3 flights of stairs. Come on, you guys are young. But when my office used to be up there during advising, my advisors would come up and be like, Dr. Brown. I'm like, first of all, you got to get in shape. 2, what happened is by the physical exercise, working your hamstrings and your quads, right? Your blood pH shifted a little bit. All right. It became a little, more acidic because those muscles were metabolizing, building up CO2 metabolic waste. So sensed by the chemoreceptors, your medulla responded, quick fix, increased minute ventilation, right? You blew off the extra CO2 in a minute or 2, you're fine, right? Oh, and by the way, a good metric of someone's cardiovascular health is how soon their heart rate and respiratory rate return to normal after they stop exercising. Everyone, after they've had a vigorous exercise, climbing 3 flights of stairs, running a mile, is going to pant. And in a minute or 2, they should be fine and their heart rate should be dropping. If someone persists in having an elevated heart rate and panting 10 or 20 minutes after exercising, that might be an indicator that they've got some problems. But anyway, you pant, get rid of the excess CO2. Blood pH comes back up to what it should be. Now, if you breathe too quickly, you can actually induce problems as well. You're going to shift your blood pH. You're losing too much CO2. Your blood pH drops. I'm sorry, it rises, opposite. Got to have my tea this morning. I haven't had my tea. So with losing the acids, you have respiratory alkalosis, which is just as bad as respiratory acidosis. So rapid breathing causes respiratory alkalosis. Stimulus is low blood CO2. Then sensors sense it, chemoreceptors, medulla responds. And now it's going to, let me move this out of the way, decrease minute ventilation. So you're going to breathe less frequently and less deeply. Breathe very shallowly. And so you retain a little bit of CO2 and your blood pH comes back down to what it should be. And the medulla, it's the quick fix, right? Because I know you're studying this for the cardiovascular chapter that's coming up, right? The medulla is the quick fix and the hormonal fixes to whatever are long fixes. This is a quick fix. We're talking about a minute or less. Just like when you changed posture, your heart rate and blood pressure went up, but it didn't last very long. In about 10 minutes, it's gone. It goes back to normal. Same thing here. Same thing here. Okay. Now, just to reinforce what I talked about, blood with high CO2 when you're not respiring enough is acidosis. Blood with lower CO2, so you've lost too much CO2, this can happen with hyperventilation, so you have respiratory alkalosis. Now, back in the chapter 2, part 1, metabolism, there's acidosis and alkalosis. You can have metabolic acidosis and metabolic alkalosis. That's a drop in blood pH separate from the respiratory system based on what molecules are you processing, are you metabolizing? Are you metabolizing lactic acids? Are you metabolizing ketones? Are you, remember all that? That's separate from respiratory stuff, all right? And I delineate the two because you're going to see we're not done with COVID, my friends, okay? It's going to keep coming back every year, probably becoming less fatal and more like a bad flu, but we're probably going to be seeing it for a long time now because it's been 3 years now and we're still out there. So know this respiratory stuff, no respiratory acidosis, alkalosis, because a patient who's got COVID, who's chronically fighting this inflammation in their lungs, they're not going to be respiring very well. And their blood CO2 is going to rise. They're going to have respiratory acidosis. Okay. Metabolic component. I'm not going to worry that. I just want to bring it up, but you don't have to study this stuff again. From a pen. I just bring it up to delineate between the two. These are two separate different things. You have to know if someone's blood pH is off. Why is it off? Is it because of what they're metabolizing or not metabolizing? Because that's a different treatment. Or is it because of what their lungs are doing or not doing? You need to know the difference between the two so you can treat them effectively. Okay, so we'll end, we got time, with some hemoglobin disorders, and I'll just talk about maybe the most common ones that you will likely to see. Okay, so do not memorize all this, but just know the stuff in bold colored terms, okay? But in anatomy, did you guys cover blood anatomy? Did you talk about things like structure of hemoglobin or different types of, no, it's okay, it's all right. So anyway, our hemoglobin is the respiratory pigment that's carried on our red blood cells that carries oxygen, has a heme component, and each heme group binds with a single oxygen molecule, and every red blood cell has millions of hemoglobin molecules associated with it. So there's a great capacity for carrying oxygen. Now, hemoglobin that is bound to oxygen and 97% saturation is normal. If you put a pulse oximeter on a patient, their oxygen saturation in their blood should be 97%. In a COVID patient, when they start dipping below that to 90% or upper 80s, that's when you think about intubating that patient, okay? Because their lungs are no longer able to keep them ventilated. They're not getting enough oxygen. But anyway, so that's what you'll see, okay? And that arterial blood is bright red. If you've ever seen arterial blood, it's bright red because of the saturation of the hemoglobin. Venous blood is basically has hemoglobin lacking the oxygen or lacking a lot of oxygen. And venous blood is more maroon or dull red color. And I'm sure you've all seen venous blood. All right, so there's a difference between the two. And if you see arterial blood, it's usually spurting, all right, versus venous blood. So oxyhemoglobin, deoxyhemoglobin. Now, I mentioned, I forget when, but I talked about the dangers of your blood being acidic way back in chapter 2, part 1, metabolism. And I said, when your blood pH is too acidic, your hemoglobin doesn't want to release oxygen when it gets to the tissues. So we've been talking about arterial blood comes to your tissues like the muscle tissue, and oxygen's high, and in the tissue, oxygen's low. So it wants to go from high in the artery to where it's low in the tissue, so your tissues get oxygen. If your blood pH is too acidic, the hemoglobin won't let go of that oxygen. And now your tissues are hypoxic. They're oxygen starved. So low blood pH is a problem because our hemoglobin doesn't act like it should when blood pH, the chemistry is off. All of homeostasis will be off when blood pH is off. So talking about hemoglobin disorders, we just left winter, I think officially. I think the weather's going to start warming up and we're not going to have any more freezes. But in the wintertime, you will, I guarantee it, every year in the hospital, you'll get a case of someone coming in with carboxyhemoglobinemia. People who basically run kerosene heaters in their house or even just a fireplace, okay? Carbon monoxide gas, especially is given off by fireplaces, kerosene heaters, all kinds. They bring them right into their house because maybe they don't pay their heating bill. I don't know what, but carbon monoxide gas is given off. You can't smell it, you can't see it, you can't taste it. This is why everyone should have carbon monoxide detectors in their home, especially if they have a fireplace or burn a kerosene heater in the house, which is a bad idea. But what happens is carbon monoxide gas has a higher affinity for your hemoglobin than oxygen does. So carbon monoxide gas molecules bind to the hemoglobin, leaving no place for oxygen to bind. And your tissues can't use carbon monoxide gas to make ATP, right? They can't act as a final electron acceptor in the electron transport chain and making ATP. Your cells die, especially cells with a high oxygen demand like your brain. So you're going to go unconscious and then you're going to die unless someone can save you, because that's it. You fall asleep, you never wake up because your brain shuts down. It's not getting enough oxygen. So carbon monoxide gas binds to hemoglobin. That hemoglobin is now carboxyhemoglobin. It won't carry oxygen to your tissues. Your brain goes without oxygen. It's just like a stroke. Brain shuts down, you shut down. So the carbon monoxide detectors are pretty important because it will detect the increase in that gas. This can also happen, and it's kind of sickening to think about, but people who commit suicide in their vehicles by taking a tube, attaching to their exhaust system, and having that run into their car, that's carbon monoxide gas coming out the exhaust. And that's what's happening to them. It's actually not a bad way to go because you kind of fall asleep and then you're gone, but still it's carbon monoxide gas changing your hemoglobin to something that your body cannot function with. Okay, so carboxyhemoglobin has heme groups bound to carbon monoxide gas instead of oxygen. So there's no oxygen coming to your tissues, all right? And let's see, body actually produces a tiny amount of its own carbon monoxide. There's always some of this hemoglobin around, but it's not the majority of hemoglobin. So active non-smokers should not have more than 1.5% carboxyhemoglobin. Okay, so smokers, that's also giving you off a little carbon monoxide gas. Higher percentages than this can actually lead to this carbon monoxide poisoning that I'm talking about. All right. Okay, so treatment is hyperbaric oxygen therapy, where they put you in this chamber with a lot of oxygen under high pressure to force that into your lungs and displace and remove that carboxyhemoglobin. All right, but you have to catch someone before it gets to this point. Something else that you might see, because we're in an agricultural area, the PD. I used to live next to a sod farm. Fortunately, the person who owned it kind of gave up. They weren't selling sod anymore. This is when we had the economic downturn, the recession, and no one was buying turf. All right, so he wasn't getting any business, so he wasn't making any money. He couldn't make the payments back. Oop. But so I was concerned. I said, this was a sod farm. They were applying nitrate to make the grass grow probably for decades. And whatever plants, grass, whatever, don't use in the nitrate, with the rain gets washed off, gets into water systems, seeps down into the underground water aquifer where it can stay. Here's the problem. So I knew about this, but a lot of people don't. If you live out in the country and you have a well, however deep that well goes, if you're near an agricultural area, or even a water treatment facility, I saw a house being built just 20 feet from a water treatment facility on Pimlico Highway. I'm like, good luck with that. Get your water tested. Nitrate, if it's in the drinking water. For an adult, probably not a problem. The long-term exposure to nitrate is increased with things like bladder cancer and other cancers. But for a baby, if you make formula with nitrate contaminated water, that little baby's metabolism is sky high. They're growing and metabolizing so fast that that nitrate contaminated water changes their hemoglobin. So methemoglobinemia is when your hemoglobin's iron is ferric rather than ferrous. This is why they say you have to take some chemistry, inorganic chemistry for this class, but the chemistry is minor. That difference between ferric and ferrous can be life-threatening to a baby. So this hemoglobin is called methemoglobin, and it has a decreased ability to release oxygen at the tissues. All right, just like if your blood was too acidic, but in this case it's not, it's the hemoglobin itself that doesn't want to release the oxygen. So a tiny little baby that's growing so fast, metabolizing so quickly, they can't tolerate that. They can't function. So the babies are chronically oxygen starved and they turn blue. It's called blue baby syndrome. Did you hear this in microbiology? I think Dr. Pryor used to cover it. So they turn blue. That is never normal. If you ever see a blue baby, person comes in with their baby and the baby looks blue, you admit them. Okay, something's going on. Well, anyway, so the nitrate in the water causes the formation of that methemoglobin. Now, the good news is it's easy fix, kind of easy, maybe expensive for some people. So first of all, you need to get the well tested, which pretty much when a well is dug, you usually do send a sample off to the CDC or DHEC or something like that. And if it comes back positive for nitrate at levels that are above what the CDC recommends, you can get reverse osmosis filtration system for the whole house. And so it's going to remove that nitrate. All right. So that's the fix. So I had my water tested for nitrate. The well was 300 feet deep. That's pretty deep. I made sure it was deeper than what the sod farms wells were, and we were good. All right. But that is something to consider because we live in an agricultural region and a lot of people live out in the country more and more so every year. And they should always have their water tested because could be nitrate in it. Neonatal jaundice. How many people knew someone who had a baby who had neonatal jaundice? Okay, so I'll ask some questions here in a second. So when the babies come out, they're not fully cooked. A lot of organ systems are still forming, functioning, getting functional. But when a baby goes from in the womb, surrounded by amniotic fluid, and mom's respiratory and circulatory system is pretty much doing all the hard work, taking away baby's CO2 waste, delivering oxygen through placental vessels that diffuse across the placenta to the baby. Once the baby's born, they're on their own. There you go. You're on your own. Good luck, respiratory system. I hope you can take over now. What happens if sometimes they're not? We talked about that. We talked about neonatal jaundice and everything. I think we did before. Maybe not. I can't remember. There's a chapter. I think it was the circulatory chapter. Anyway, they must now change their hemoglobin from fetal hemoglobin, which was certainly fine for their circulatory system when mom's body was doing all the hard work. But once the baby's born and they're autonomous, they must change their hemoglobin to adult hemoglobin because now the demands on the respiratory system is greater. They're on their own. They must get all their oxygen and get rid of all their CO2 waste on their own because mom's gone now, not gone, just you're not in the body anymore. So the body starts breaking down the fetal hemoglobin to produce adult hemoglobin. The liver is supposed to remove the bilirubin in the red blood cells having that fetal hemoglobin. The body doesn't want to waste anything, but that bilirubin is a yellow pigment. When the baby is born, if their liver is not fully functional yet, it'll get there, but yet, it can't get rid of all that fetal hemoglobin and bilirubin by itself. The liver's just not quite up to the task yet. So that bilirubin causes the baby to turn yellow. Now, if it's really bad, they can give the baby ventilatory assistance in a neonatal intensive care unit, but sometimes that's not bad, okay? And in that intensive care unit, they will flood the baby with blue lights, and the blue lights will basically break down that bilirubin into something soluble that the kidneys can get rid of in urine. So sometimes it's really bad, and the baby must stay in intensive care with the blue lights being monitored. Sometimes it's not bad. Did you have the bad, or you took the blue lights home with you?
We did the blue light blanket.
Tell me about the blue light. I don't know about the blue light blanket.
So basically, it's just like ginormous blanket that's got the blue lights inside of it, and so you just plug it into the wall, and then you just put it around you and the baby, and so you can hold them so they get that skin-to-skin contact, which also helps with that, as well as the blue lights breaking it down.
That is awesome. I did not know about that. That's cool. Okay. And you were in the hospital. You could do this on your own at home?
They can send a blanket home with you.
Nice.
Their insurance.
That is so cool. I did not know about that. I'm going to have to Google that next when I get out of here because I didn't know about that. But anyway, so that's very common. All right. Very common, but fixable. Fixable. Okay. Fetus has different form of hemoglobin, fetal hemoglobin, than mom who has adult hemoglobin. Once the baby's born, they stop producing it and they start producing the new hemoglobin. Well, all those red blood cells that carry the fetal hemoglobin, you got to break those down and recycle everything. But the bilirubin that's released, if the liver is not quite up to task, they can turn them yellow. But now we know, hey, blue light in NIC unit or blue light blanket. That's so cool. Okay, and this is the last one. And you will see this because it's a homozygous recessive condition where if you inherit an allele for sickle cell from mom and an allele for sickle cell from dad, you now have both those recessive alleles and you will express sickle cell anemia. Well, sickle cell anemia, most people think it's a red blood cell disorder, but actually it's a hemoglobin disorder. So normally we have adult hemoglobin. If you inherited this condition, you have red blood cells with hemoglobin S, the S for the sickle cell. And what happens is it's the hemoglobin S that makes the red blood cells deform into the sickle shape, thus it gives that the name for the disorder. And then the sickled red blood cells don't carry as much oxygen. Their abnormal shape makes other red blood cells want to stick to them, and it forms a clot or a thrombus. And then if you have a thrombus, we've covered this in the cardiovascular chapter, that thrombus could float down an artery very, very small in diameter and plug it. All right. So when it's floating, it's called an embolism. When it plugs artery and you have no blood flow past that blockage, that's an ischemic event, loss of blood flow to something. Now, interestingly, they used to think that it was just the homozygous recessive peoples that would express the sickle cell anemia, but we now know that even being heterozygous for it, you can have, because I've had some students that say, yeah, I'm heterozygous, but I still have some symptoms. They're not as bad as being homozygous, but I still have some symptoms. All right. So they used to think being heterozygous was more protective, but now we're seeing that there are some subtle symptoms of that, even if you have only one allele for it. And you will see it, very common. And that, my friends, ends the respiratory chapter. So it'll be all kidneys starting on Monday. All right. Have a great weekend. It looks like it's going to be wonderful out. I hope you get out and enjoy it.